Thank you very much for inviting me to speak today. These are my financial disclosures, none of which are relevant to this talk. The most common age-related eye diseases are cataract, glaucoma, and age-related macular degeneration. Cataract is the most common, but is relatively easily treated with cataract surgery, which has an over 95% success rate. Conversely, AMD is a much more difficult disease to manage. Age-related macular degeneration is the leading cause of loss of vision and blindness in patients over 65. It's the third leading cause of loss of vision worldwide, and it's very expensive to treat. In 2010, the cost of treating neovascular age-related macular degeneration was about 10% of the Medicare Part B drug cost. Age-related macular degeneration is staged, and the estimated US prevalence of intermediate stage age-related macular degeneration, or AMD for short, is about 8 million people. And of the more severe stages, neovascular AMD and geographic atrophy, about 1 million people each. One can see on the graphs on the right that the prevalence rises with age of both AMD in general and late-stage AMD, and that it is higher among Caucasian Americans than among African Americans. Here are the stages of AMD. This is intermediate stage, multiple small drusen here or here, plus pigment changes. Drusen are composed of lipoproteins, complement, and immunoglobulin. Late stage AMD is what causes visual loss, either from the formation of new blood vessels, as we can see here with bleeding underneath the macula, or geographic atrophy, as we can see here, where the central area that one would see well with is damaged and lost. The import of intermediate stage AMD is that once you have it, you're at high risk for progression to late stage AMD. Now, we know from some work that we've done using the longitudinal study of the ocular complications of AIDS, that patients with AIDS have a slight excess of cataract over other cohort studies using similar methodology, particularly at younger ages. We also are able to evaluate the retinal vascular using semi-automated methods to evaluate the caliber of the central retinal arteries and veins as they emerge from the disc, and converting them to measurements called the central retinal artery equivalent and central retinal vein equivalent. Both of these decrease with age, and when we compare patients with AIDS to patients who are HIV uninfected, we find that they have vascular calibers that are about similar to those between 11 and 24 years older there, again, suggesting some accelerated or accentuated aging in patients with AIDS. Now, the study I'm going to talk about is the longitudinal study of the ocular complications of AIDS. It was a prospective observational cohort study started in 1998. Enrollment finished in 2011 and follow-up in 2013. All patients had AIDS. They were recruited throughout the United States with and without ocular infections and with a wide range of CD4 T cells. They were given a detailed medical history with chart confirmation of all diagnoses, routine laboratory testing, and of course IRB approval and written consent. Retinal photographs were taken on about 99% of the cohort participants at enrollment. There were 2,392 participants, of whom 535 had ocular infections, and one cannot evaluate the retina for age-related macular degeneration in the presence of an infection that causes extensive retinal damage. 32 patients had no photographs. So the study population was 1,825 persons with AIDS. We also had 5- and 10-year follow-up retinal photographs, and they were all graded at a centralized reading center by graders unaware of the clinical findings of the patients. A standardized system was used to grade the photographs for grading for age-related macular degeneration, and the primary outcome was intermediate stage AMD. This was chosen because it's more common, about tenfold more common than late-stage AMD, and also because there are some data to suggest that nucleoside reverse transcriptase inhibitors may interfere with the development of retinal neovascularization. After we evaluated both the prevalence and incidence of AMD in the cohort, we compared them to HIV uninfected cohorts, which use similar methodologies. This is the characteristic of the 1,825 patients in the study as a whole. Relatively young, mean age of 43, overwhelmingly men, mix of races. Patients had had AIDS for on average 4.3 years. Of note, approximately half of the patients were current or former smokers. Antiretroviral therapy at or prior to enrollment was highly common, 94%, and as one will see in the follow-up study, over 99% used it during follow-up. Median CD4 T cell count at enrollment was about 200, with a wide range, as one can see, from the 25th to 75th percentile. It's important to note that this was a cohort where there had been profound immune compromise at some point in the past. The median nadir CD4 T cell count was 44, again with the 25th to 75th percentile of 13 to 113. About 20% were co-infected with HCV. This is the prevalence study of AMD at baseline. Overall, about 10% of patients had AMD, and as one can see, the prevalence increases with age, as one would expect. Smoking was a risk factor for AMD, and it's a risk factor in HIV uninfected people as well. An unexplained observation is that in patients with injection drug use and patients where the HIV risk group was heterosexual transmission appear to have a higher risk of AMD than those from other risk groups. Diabetes, hypertension, and cardiovascular disease all were associated with AMD, as they are all age-related diseases. Things that were unassociated are shown on the left. Specifically, antiretroviral therapy was unassociated, and if anything, the rate of AMD was lower in those who received antiretroviral therapy. No specific drug was associated with AMD. Also, enrollment CD4, nadir CD4, enrollment HIV, maximum HIV prior to enrollment, and hepatitis C all were unassociated with AMD. In the multiple regression of risk factors, age was associated with prevalent AMD, injection drug use and heterosexual transmission remained associated, and current smokers appeared to have an excess risk of AMD, again, consistent with what we see in HIV uninfected populations. Now, we were able to compare our prevalence of AMD with the Beaver Dam offspring study. This study used the same reading center and the same methodology. And when one does an age and gender adjusted prevalence, one can see that there is approximately a 4.1-fold increased prevalence of AMD in persons with AIDS versus an HIV uninfected population. The next study was to evaluate the follow-up photographs. As one can see, we had, of the 1825 who had neither opportunistic infections and had baseline photos, about 189 had AMD and were not available for evaluation of incident AMD. The numbers you can see here show those who died with less than 5 years of follow-up, those who were enrolled too late to have 5 years of follow-up, and those who were lost to follow-up, resulting in a study population of approximately 730 patients. The mean age of this population is similar to that of the 1825 in the prevalence study, with similar risk factors. Again, smoking, approximately 60% were current or former smokers, with similar use of art, including 99% using it during follow-up, similar CD4 plus T cells and HIV loads, and about 20% with HCV co-infection. These are the risk factors for incident AMD. The rates are greater based upon greater baseline age, although this is not significant. The Cox regression shows that current and former smokers both had an increased risk of AMD. We were able to compare our incidence of AMD with the multi-ethnic study of atherosclerosis. Again, this was a group that used the same reading center and the same methodologies. And one can see that the two groups had different baseline age. The MESA study had an older age. We were unable to do age adjustment in this comparison, but we were able to gender and race adjust. And despite the older age group in the MESA study, patients in ELSOCA had a 1.75-fold increase incidence of AMD with an adjusted incidence of close to 1% per 100 person years. Sorry, 1 per 100 person years. So we know that patients with AIDS have an increased prevalence of AMD and an increased incidence of AMD. This finding is consistent with the accelerated, accentuated aging phenotype seen in ART-treated, immunorestored HIV-infected persons. Smoking is a significant risk factor for AMD, as it is in HIV-uninfected persons. It's not related to antiretroviral therapy, HIV load, or CD4 T cells. And we know that there are some markers of systemic inflammation in HIV-uninfected persons that appear to be associated with AMD. And therefore, we looked in our population for whether or not systemic inflammation was associated with AMD in patients with AIDS. We performed a case control study of participants with AMD versus those without, using 2 controls for each case matched by decade of age, gender, and race and ethnicity. We had cryopreserved baseline plasma specimens, and we assayed them for biomarkers using immunoassay kits. Plasma biomarker concentrations were log base 10 transformed in order to get a normal distribution, and then standardized to standard deviation units because of the different dynamic ranges, and quartiles were compared. We looked at mortality as an outcome, and hazard ratios are adjusted for HIV load, CD4 T cells, and the biomarkers. These are the biomarkers we evaluated, including C-reactive protein, IL-6, IP10, soluble CD14, soluble CD163, KT ratio, and FABP. And you can see the inflammatory role that they play in this table. This is the baseline characteristics of the study population. You can see that we were reasonably well matched on age, gender, AIDS-defining illness, and the use of antiretroviral therapy. There were no significant differences in HIV load, CD4 T cell counts, or CD8 T cell counts at baseline. Now, AMD is associated with mortality in our population, and one can see a 48% increased risk of mortality if a patient has AMD at baseline. These are the baseline results of the biomarkers, and only IL-6 has a suggestion of being associated with AMD. However, several of the plasma biomarkers are also associated with mortality. One can see here in the graphs that CRP, IL-6, soluble CD14 all appear to be associated with AMD. And here are the hazard ratios of these, whether one looks by comparison per quartile or the 4th versus the 1st quartile. And those are significantly associated with AMD, with mortality rather. We did a multiple Cox regression of mortality for AIDS, and in the multiple regression, AMD ceased to be associated with mortality. HIV load and CD4 T cells were not surprisingly associated with mortality. So we looked at what happened. And in the multiple Cox regression, CRP, IL-6, and IP10 remained associated with mortality. So we did a stepwise variable selection of mortality on AMD in patients with AIDS. And one can see AMD alone, again, at 48% excess mortality. But as one stepwise adds the biomarkers, this association is lost. Conversely, HIV and CD4 do not make as big a difference in the association with mortality as do the biomarkers. These data suggest that intermediate stage AMD is associated with increased mortality in patients with AIDS, that the plasma inflammatory biomarkers are associated with mortality, which we know is present in both HIV-infected and HIV-uninfected aging. And the AMD association with mortality was attenuated in the multiple Cox regression by the inflammatory biomarkers, suggesting that that AMD mortality and systemic inflammation are all related. We know from study in patients who are HIV uninfected that late-stage AMD, especially neovascular AMD, is associated with mortality. But intermediate stage AMD is not associated with mortality in the HIV uninfected. Therefore, this suggests that there is an intensified phenotype in patients with AIDS. Finally, AMD takes a long time to develop, years to decades. So it might be unreasonable to expect an association of biomarkers with prevalent AMD, given that it is a one-time evaluation. We've begun to look at the association of baseline biomarkers with incident AMD. And as one can see here, CRP, IL-6, and soluble CD14 all appear to be associated with incident AMD in our preliminary data. Again, suggesting that there is a strong relationship between systemic inflammation and the aging eye, or at least in AMD in this group. The conclusions of our work are that there is an increased prevalence and incidence of AMD in patients with AIDS. This is consistent with the accelerated and accentuated aging phenotype seen in patients who are ART treated and immunorestored and HIV infected. There's an increased mortality in AIDS of persons with AMD, which appears to be associated with systemic inflammation rather. Systemic inflammation appears to be a risk factor for incident AMD. The limitation of this work is that the population is a population of patients with AIDS, not with earlier stages of HIV, and it's a population that has seen low CD4 T cell counts prior to enrollment in the cohort. And so one needs to be careful about generalizing it to earlier stages of HIV, as we do not have data in that group from this cohort. I want to thank you very much for inviting me to speak and for your attention to my talk. These are my funding, without which this could not have been done, and this work could not have been done. Thank you.